It's a 46-year-old man with a history of chest pain and shortness of breath. He recently underwent a right colectomy for colon cancer. He now has 2 days of pleuritic chest pain and progressive shortness of breath. No fever, chills, or cough. He also has left leg pain and swelling for about 1 week. Past medical, this is not a diagnostic for colon cancer, he's Duke's B2 resected about 3 weeks ago. He has osteoarthritis. He's only on oxycodone for post-op pain, which he's not taking very much. His father died of a PE, and his brother also had it. He's in mild respiratory distress, pulse 112 and regular, and his blood pressure is fine. He's saturating 89% on room air. He has no jugular venous distension. His lungs are clear. He's tachycardic, the normal S1 and S2, and no extra sounds. Abdomen is benign, and despite him saying he had swelling, he couldn't find any swelling at all. His blood is warm and well perfused. White count is 9, hemoglobin's 13, he's got normal lights, chest x-ray is normal, and he's got sinus tachycardia. So, what do you think is the most likely diagnosis? So a couple people thought E, which was aortic dissection, a couple pneumonia. Most thought, obviously, pulmonary embolism was by far the most likely. Now the nice thing is, just by figuring out where the group is, you can decide where to go. Right? If the group says this is pneumonia, then you can just go, okay, well, what's pro and con pneumonia? Say, well, pneumonia is unlikely. There's no fever. There's no cough. There's no infiltrating of the chest. What about acute coronary syndrome? Well, that's unlikely because there's a pleuritic chest pain, lack of risk factors, and there's unremarkable disease. You can see how you can take the talk in the direction that you want to go based on that. We don't have to go through all of these. Then he goes, okay, so everybody chose pulmonary embolism. Let's go to pulmonary embolism. And you can see how you can use that as a branch point, and then eventually link back. And it's very easy to set this up with the software that we have. So, consistent with PEs, pleuritic chest pain, shortness of breath, family history of venous thromboembolic disease, no other clear explanation for the symptoms, had a normal chest x-ray, right? It's probably what you guys used as the reasoning behind saying PE is the most likely diagnosis. So, the interesting thing is, what about this? What percentage of patients with PE have a normal chest tone? Really interesting, especially that no one got the right answer. The right answer is actually 12%. Now, the reason why patients who have PE have an abnormal chest x-ray is not because of PE. It's because they've got congestive heart failure, they've got lung cancer, they've got pneumonia, they've got all those other things that go along with it. But somebody said that's a tricky question. You're absolutely right. It is a tricky question. Because if you said, how many patients have chest x-ray findings of a PE, number would be very low. Compared to what you guys said. But when you take all patients who have a PE, only 12% have a normal chest x-ray. Does that make sense? Mm-hmm. So again, this is a great way to assess people's knowledge of things. We got to work on that a little bit. Okay? So then you start thinking about, well, we've got a clinical reputation consistent with PE. So what do you want to do next? Do you want to do an MRI of the pulmonary vessels, a CT, a VQ, a pulmonary agram, or a lower extremity Doppler? Excuse me. So most people said B and C, a couple E and F. So most people want to go to VQ, that's interesting. And then CT scan.